Hello everyone, welcome to Surgical Insights with Dr.Deepz. Today I will be discussing about hypersensitivity reaction. Often appears difficult because they involve multiple disease and immune mechanism. However, I make one simple mnemonics that can help solve almost every hypersensitivity questions, which is acid EGGT. So I would like to first of all write the mnemonics. Okay, acid EGGT. Okay, A for anaphylactic, and C for cytotoxic, I for immune mediated, okay, and D for delayed type. So I would like to also tell you one thing, that acid EGGT, EGGT, anaphylactic, that corresponds to IgE, okay, immunoglobulin E, and cytotoxic corresponds to IgG and M. Okay, same thing with immune mediated, corresponds to IgGM. Okay, finally delayed type corresponds to T cell mediator. So this is acid, and this is EGGT. Okay, this mnemonics actually simplifies and avoids most of the confusion whatever you have in pathophysiology. So this is the way you can easily memorize. So now I would go to direct topic. First is type 1 hypersensitivity, as I said, acid EGGT. So anaphylactic shocks corresponds to type 1 hypersensitivity reaction. So one of the reason I'm taking hypersensitivity reaction, because this topic is interrelated with upcoming topic of shocks. So this is the interrelated topic. So main scenario examiner provide is about the food allergy, bee sting or scorpion sting, or drug reaction with penicillin they may give you. And in MRCS like exam, they focus more on latex exposure. And latex exposure can be also seen in type 1 hypersensitivity reaction and type 4 hypersensitivity reaction. So I will be discussing the main differences later on. So as of now, food allergy, definitely they will give you the example of peanut, shellfish, and may have an abdominal cramp and vomiting with a child age with something like 4 to 8 years. Okay, presentation with peanut allergy. So type 1 hypersensitivity reaction you have to know, and IgE is mediated antibody. Okay, and here you have to know mast cell is very important. It acts on mast cell first of all. Okay, and there will be a release of histamine, leukotriene, and it may cause vasodilation, bronchospasm, and increased vascular permeability. Okay, and onset is within 60 minutes. Okay, within 60, less than 60 minutes I can say. Okay, so common features here: pruritus is something like itching, urticaria, angioedema, and next is wheeze, hypotension, and collapse. Definitely they may give you an example of collapse most frequently in MRCS, and latex related thing you have to know. Okay, treatment here: adrenaline intramuscular, and this is the first line treatment, and airway breathing circulation procedure you have to do, and antihistamine and steroids can be given for any other allergens detected. Okay, and next thing is IV fluid with O2 for breathing difficulty. Okay, so if your patient presents with latex exposure, I'm discussing here because latex exposure is very important. And on exposure of latex, gloves, balloon, or catheter, whether patient develops reddish, itchy, and urticaria, angioedema, and collapse within the minute. This example they may give you. I will be discussing in last session with example. So here I can just tell you how they ask question. And think about allergy, immediate, itchy, and airway circulation, which is anaphylactic type 1. Okay, you have to know this. Type 2, next is hypersensitivity reaction. You need to know about scenario MCQ style. So hemolytic anemia exclusively in young women with fatigue, pallor, jaundice, and dark urine, and maybe splenomegaly, okay, and low hemoglobin, high LDH, okay, lactose dehydrogenase, okay, and indirect bilirubin also increases. You have to think about jaundice and hemolytic anemia combination. You have to think, okay. And immune thrombocytic purpura is also one of the example IgG mediated, as it is IgG mediated. So there will be EC bruising, petechia, and epistasis, isolated low platelet, and other cell lines normal. So they will be asking this question and this question. Think about this too. Hemolytic disease of newborn, which is anti-D antibody, IgG cross placenta. They will ask you this. Very rarely, not here. Goodpasture syndrome, they will ask in MRCP with young man with hemoptysis, dyspnea, renal impairment, and anti-GBM antibody. So this is, they will ask about lung and kidney involvement seen in Goodpasture. Myasthenia gravis, yeah, ptosis, diplopia, fatigable weakness, and anti-acetylcholine receptor antibody, IgG. Here, this is just to remember you have to do. Okay, and transfusion reaction is most frequently asked in perioperative. Okay, perioperative, along with fever, chills, back pain, hemoglobinuria during or within the hours of transfusion. And definitely more than hypersensitivity, they will ask you the complication, as I discussed previously, hyperkalemia complication. Okay. And drug-induced cytopenia, recent heparin thrombocytopenia, HIT. Okay, and next is drug-dependent IgG antibodies. They will be asking more about transfusion reaction and about too. And the key points that you have to remember, as I taught, IgG, IgM, it is EC acid EGGT. You have to just remember. And antibodies here target surface antigen or extracellular matrix. And mechanism is, I will be teaching complement activation in upcoming session. Okay, with opsonization and phagocytosis, and ADCC, antibody dependent cell mediated cytotoxicity. And onset is, this is hours to day, that is minutes to hours, this is hours to day. Okay, and example, they may give you autolytic, autoimmune hemolytic anemia. Okay, and immune thrombocytopenia, Goodpasture syndrome, Graves disease, and hemolytic disease of newborn. Then drug-induced, which is penicillin. Penicillin mostly they will be asking, and transfusion reaction you have to know. So exam part of you, mostly they will ask you allergy. First one anaphylaxis shock, and fourth one is delayed type. These two are most frequently tested. Antibodies, very frequently they may ask you about hemolytic anemia, and they will also ask you about antiphospholipid syndrome. This is most important, antiphospholipid antibody. Okay, they will give you a classic scenario like recurrent abortion associated with swelling of legs, swollen legs. So this they may ask you, and sometimes antiphospholipid, they may give you another name, anticordolipin enzyme. This they may give you to confuse, so you have to. This is most frequently tested in MRCS. Next thing is type 3 hypersensitivity reaction. So here you have to know all the example. Post streptococcal glomerulonephritis could be example. a child with a sore throat 1 to 2 weeks ago, and now puffy eyes, edema, tea color urine, and hypertension. And lab related is C3 lesser and normal C4. How to know? Okay. Again, serum sickness. You have to know about fever, rash, arthralgia, lymphadenopathy, and 7 days after receiving foreign serum, there will be a this thing, immune complex mediated, and C3, C4, okay, decrease. Systemic lupus erythematosus, they will ask you in pathophysiology with all those ANA positive diseases. Yeah. And vasculitis, they may ask you polyarteritis nodosa, which is middle-aged man with fever, weight loss, abdominal pain, and hypertension, raised renal function test. C3, C4 actually consumed in type 3 hypersensitivity reaction. So typically C3 is decrease rather than increase. So everyone should know complement cascade 3 and complement cascade 4 it is actually. And you have to know this, not to be confused. And hypersensitivity pneumonitis, farmers or bird fancier with cough, dyspnea, and fever exposure. Okay, fever after exposure to organic dust. Okay, may lead to decrease C3, decrease C4 may be normal. Okay, complement cascade 3 and complement cascade 4. You have to know. Related to polyarteritis nodosa, they may be asking pathophysiology question. P polyarteritis ANCA. Okay, and related to Vaginous granulomatosis, it is C ANCA. You have to know this, both markers. Key points to remember is type 3 immune complex IgG mediated, as it is acid egg T. Third type is actually IgG, IgM again. Deposition in tissue, vessel glomeruli, and synovium silk lungs. Okay, activates complement inflammation, tissue damage. Onset hours to days. Okay, with this you have to know rashes, arthritis, and nephritis along with low complement. Think about type 3. Okay, type 3, you have to think hypersensitivity reaction. And the classic example infection may be post streptococcal glomerulonephritis, serum sickness, systemic lupus erythematosus. Most of the examiner love to ask Muller rashes. Okay, Muller or butterfly rashes. Okay, so this is most confirmed question in most of the exam. Okay. And polyarteritis nodosa also vasculitis, it is one of the important with P and K, and they will ask about involvement of organ. And next is hypersensitivity pneumonitis. You have to think about this. Okay, so I is immune complex deposit in tissue, complement activity activates inflammation, and then type 3 presence. Type 4 hypersensitivity, it is delayed or T cell. Okay, delayed or T cell mediated, you have to know. So delayed, most of the doctors are aware of tuberculosis. Okay, tuberculin PPD skin test, it actually in duration and erythema 48 to 72 hours after PPD. Okay, tuberculin skin test. And injection in previously exposed individual, he delayed 2 to 3 days in duration. Okay, so here you have to know onset is 24 to 72 hours from the exposure. Okay, from the exposure. Allergic or contact dermatitis, itchy eczematous rash at the site of contact with nickel, poison, IV, and cosmetic, rubber, etc. Delayed is 1 to 3 days, and localized rashes. Okay, and tuberculosis from the above, tuberculin skin test, tuberculosis also comes because granulomatous inflammation is very, very important. Okay, key is chronic granuloma TB exposure, that is the key. And organ transplant rejection happens actually delay. T cell mediated rejection occurs days to week, days to week. And after transplant, okay, graft dysfunction. Next is key is delayed and graft dysfunction. Okay, viral illness and T cell kills virus infected cell, hepatitis and elevated liver function test. And yeah, that's all. T cell response with no antibody. So most likely diagnosis of type 4 hypersensitivity. Delayed type is T cell mediator. You have to know. And these are all the key point you have to remember. Okay. So here, let me go to key point. Type 4 is delayed hypersensitivity as we discussed and mediated by T lymphocytes, Th1 and CD8 plus. Okay, no antibody or complement involvement. Okay, cytokine release. Okay, IFN alpha, interferon alpha and IL2, interleukin 2. And this makes to activation of macrophage, and onset is 24 to 72 hours delayed. Okay, exam basis they will give you the 72 hours, 24 to 72 hours delayed after exposure to antigen. And feature includes induration, local redness, granuloma, or chronic inflammation, which may lead to type 4 hypersensitivity reaction. So you should not be confused with type 1 and type 4, as type 1 is immediate, and type 2 is type 4 is delayed. Okay, delayed. So you have to memorize this too. In upcoming scenario, there will be a latex presentation, which is actually this is most often confused in MRCS. Okay, so how to identify this? Let me give you a hint. Okay, so sudden symptoms within minutes or less than 60 minutes after latex exposure, during surgery, after gloves and catheter tourniquets related to latex. So here urticaria, itching, hives, and angioedema, lips or eyes, and wheeze, bronchospasm, hypotension, and immediate collapse may progress to anaphylaxis first of all. Okay, and key identify rapid onset within minutes. Okay, minutes to maximum 1 hour, not more than 1 hour. Okay, and systemic features, skin or airway circulation. Think about type 1. Okay, type 1. And in type 4, how to identify it? Itchy, red, dry rashes appears 24 to 74 hours, 1 to 3 days after latex contact. Okay, and example, repeated glove use, healthcare work exposure. So how to think? Okay, so next clinical pearls is itchy, erythematous, and eczematous rash. Okay, dry, scaly, and cracked skin. Okay, localized to area of contact. And next is hands or wrist. Okay, no wheeze or no hypotension. Onset delayed is 24 to 72 hours. You have to think about delayed and rapid. That's all you have to think. Difference between type 1 and type 4 latex allergy. If it is allergy and immediate, type 1. If it is after 1 to 3 days from the contact of latex, type 4. So these are the shortcuts I have actually collected. Okay, very, very important. And everyone can pause the video and go through this. So each and every scenario is very, very important. So here I put you to clinical scenario. A 12-year-old boy presents to emergency department 2 hours after helping his father to cut the grass. He complains of rhinorrhea and itchy eyes, sneezing, and a blocked nose. Okay, he's apyrexial, no fever, with hemoglobin 12.2 and WBC is 6.8 into 10 to the power of 9 per liter. Okay, with a raised eosinophil count. And chest X-ray is clear which immunoglobulin is most likely to cause this reaction. Remember again acidity, something allergy, okay, because father cuts the grass, helping his father to cut the grass. So grass means something like allergy. So now this thing IgE, okay, acid ecti. Rest of the options won't be perfect because IgA primarily protects mucosal surface, doesn't mediate allergic rhinitis, and IgD actually functions mainly as a B cell receptor, no major role in the immediate hypersensitivity. So this is not the answer. This is not the answer. And IgG receives type 2 and type 3 reaction. So type 1 it won't help. Okay, and there is not the principal antibody in hay fever. Okay, IgM next is this is actually produced during the infection, so not responsible for allergic reaction. So ultimately your answer is IgE. So clinical scenario 2, this is 33-year-old man involved in RTA, road traffic accident. Okay, and he is initially stable and transferred to the accident and emergency department. And on arrival, he is catheterized. And 1 minute later, he becomes hypotensive and evidence of angioedema surrounding his penis. Okay, so definitely why? Because he is catheterized. He is catheterized. Angioedema surrounding his penis means type 1 latex hypersensitivity reaction. This is the only correct. 1 minute later, he becomes hypotensive, evidence of angioedema surrounding his penis. 1 minute later means type 1. And if some other example they might give, like 24 to 72 hours later, and there is a dermatitis in penisment, the answer could be type 4. And coming back to, there is a rare scenario with type 5. Okay, a rare scenario of the type 5 mentioned. Type 5 is not a part of classical gel combs classification, so it is not classically seen in any of the textbook other than MRCF. Okay, type 5. Next is clinical scenario 3. Okay, in clinical scenario 3, 74 hours old man with a prostatic hyperplasia presents with emergency department with acute urinary obstruction. 30 minutes after the urinary catheterization, he collapsed with a blood pressure of 74, 34 mercuric pressure and a heart rate of 128 beat per minute. Most likely diagnosis, what is the shock they have asked, and ultimately it is anaphylactic shock. Okay, anaphylactic shock, because rest of the shock you will be learning in upcoming session. This is about anaphylactic shock. Okay, so latex allergy mostly associated with latex allergy, anaphylactic shock. Okay, clinical scenario 4. In clinical scenario 4, 43-year-old man from Greece, okay, present with colicky right upper quadrant pain, jaundice, and pruritic erythematous rash over his body. Is initially treated with ciprofloxacin but doesn't improve. Okay, what is the most likely diagnosis? First is infection with Ursaria branchiofti. It is not at all the thing because this is related to hydatid disease. So ultimately your answer is Echinococcus granulosus. Okay, and Ursaria bancrofti, there is no evidence of filariasis, mosquito exposure, etc. So doesn't typically present with biliary symptom. So this cannot be answered. And next is type 3 hypersensitivity react. Clinical pictures due to hydatid infection. So again type 3 doesn't explain the full presentation. So this is also not the thing. And allergy to ciprofloxacin, the symptom existed before treatment failure, doesn't explain biliary. disease. So this is also not the answer. And common bile duct stones, this is also not the answer, because explains only about jaundice and pain, but doesn't explain generalized allergic rashes. So this is also not the answer. Ultimately, your answer is infection with echinococcus granulosus. Okay. So clinical scenario 5. Okay. So here 53-year-old man is due to undergo a splenectomy, and as a treatment for refractory hemolytic anemia. Okay. Here you have to underline this. This is important. Okay. So underlying pathological basis of hemolytic anemia is thought to be type 2 hypersensitivity response. Which of the following mechanism describes best about this process? So this is a typical pathophysiology question, and your answer is formation of auto antibody against cell surface. Okay, antigen. So sixth scenario, 56-year-old surgeon has been successfully operating for many years. Over the past few weeks, she has begun to notice that her hands are becoming blistering and weepy. Okay, latex allergy is diagnosed, and what are the pathological? Which of the following is pathological processes accounts for this scenario? Ultimately, this is chronic, so type 4 hypersensitivity reaction. Clinical scenario 7. Okay, 23-year-old old man presents with weight loss. Okay, and fatigue lymphadenopathy, and he is diagnosed with a tuberculosis. Okay, which of the following processes most closely matches the underlying pathological process? And your question, they have given about tuberculosis, so your answer is delayed type. Okay, type 4 hypersensitivity reaction, not more than that. Okay, finally, if you are in eighth scenario, lost, just the lost. Okay, and pathogenicity of bacillus is due to which of the following? So here we have to mention about all the possible option. Necrosis caused by expanding granuloma, no, because it is secondary to the delayed hypersensitivity response, not the primary mechanism. So necrosis, this is not the answer. Ability to multiply within fibroblast, no. This is TB mainly survives within macrophage. Macrophage. So no fibroblast. So this is also not the answer. Next is delayed hypersensitivity reaction against bacteria. Yeah, this is the answer. But first of all, much of TB tissues damage results in host immune response, and T cell mediated delayed hypersensitivity reaction produces granulomas and necrosis under the bacteria. Okay. So effect of antibodies response, this is not a feature. So here cell dominant is immunity is dominant. Actually cell mediated immunity is dominant, and antibodies plays a limited role in TB. Okay, control. So this is also not the answer. And direct toxic effect host the cell. This is also not the answer, as TB damage is largely immune mediated, and no major exotoxin causes pathology. So ultimately, your answer is delayed hypersensitivity reaction against bacteria. So with this, we finished our topic with hypersensitivity reaction. For more information and interesting videos, you can subscribe my channel, and don't forget to give a like, and further share this video to your friends. Okay, and give a like button. With this, I end the session. I would be starting with another interesting videos upcoming days. Bye.